Morning. This hearing of the Subcommittee on Government Organization, Efficiency, and Financial Management will come to order. First, apologize to all of our guests and our witnesses and my colleagues for a short delay in getting started. Given that the delay is my responsibility, I'm going to abbreviate my opening statement to get us back on track. But we are appreciative of everyone's participation here today, and especially our witnesses. This hearing is focused on the fiscal integrity of Medicare and Medicaid, and it's our subcommittee's third hearing on this issue of helping to ensure that we do right by the American people and how we handle their hard-earned dollars that they send to Washington. An important focus of this subcommittee for many years, going back to when I first joined it, my first term in Congress in 2001 under the chairmanship of Steve Horn, is how to prevent the making of improper payments by the Federal Government. And when we look at Medicaid and Medicare, more than half of the most recent years identified improper payments were within these two programs. Approximately $65 billion of the American people's money that was not properly handled on their behalf by the Federal Government. Today's hearing is looking at how these programs can do better, and we certainly appreciate our witnesses' participation and your insights and knowledge that you'll share with us, as in the past, and working with former Chairman of the full committee and Chairman of this subcommittee, and now Ranking Member Mr. Towns. Our approach has always been a partnership with Federal departments and agencies and programs. We're not out to play gotcha, but we're simply here to see how can we do better and how can we help those involved, specifically in the operation of Medicare and Medicaid, and those who work with us at GAO and the Inspector General's office, how we can improve the effectiveness, efficiency of these programs, and ultimately serve the American people through these very important programs, where more than 100 million Americans receive health care benefits, but do so in a responsible manner where we're certainly getting a good return on the investment and properly handling their money. So we will look forward to your testimony. And with that, I'm going to yield to the Ranking Member from New York, Mr. Towns, for the purpose of an opening statement.
Thank you very much, Mr. Chairman, and thank you for holding this hearing. This subcommittee has held several hearings about fraud and waste in these critical health care programs, and we must continue to do so because we need to answer the question, can we administer these programs more efficiently by reducing improper payments and fraud? Last year, Medicare covered about 50 million beneficiaries and spent approximately $560 billion, which is about 15% of the total federal spending. Medicaid, likewise, provides coverage for about 70 million people nationwide and cost the government approximately $260 billion last year, about 8% of the federal spending. These numbers are expected to grow as our population gets older. This country increases reliance over time on Medicaid and Medicare is unfortunately translating into a significant level of waste and fraud. Improper payments for Medicare was recently estimated to be $42 billion, and for Medicaid, $21.9 billion. That is a lot of money. That is the reason why both of these programs continue to be on the GAO's high-risk list. The Affordable Care Act includes a number of provisions that will enhance our efforts to fight waste and fraud in Medicare and Medicaid. Eliminating avoidable mistakes and cracking down on criminals will be important elements in achieving this goal. Today, we will look at some of the innovative steps that the Center for Medicare and Medicaid Services is taking to reduce improper payments and fight fraud. We will also examine some of the shortcomings that prevent existing programs from reaching their full cost savings potential. There is no single approach that will result in the reduction of waste and fraud in the healthcare system. The solution requires a multi-tiered approach involving stakeholders in Congress, CMS, the private sector, and law enforcement all working together in order to achieve this goal. I thank our witnesses for their testimony, and I look forward to hearing your recommendations and suggestions that we might make. So on that note, Mr. Chairman, I yield back.
Thank you, Mr. Towns. Appreciate your testimony. We will now ask unanimous consent that our distinguished colleague from Minnesota, the gentlelady Representative Bachmann, be allowed to participate in today's hearing for both the purpose of questions and an opening statement. And without objection, so ordered. I now yield to the gentlelady for her opening statement.
Chairman Platts and Ranking Member Towns, I thank you so much for your consideration and graciousness allowing me to be able to testify briefly before this committee today on this critical program. And I thank you also for the bipartisan way in which this committee is moving forward on this subject, as we are on the cusp of a major expansion in Medicaid in the United States. It's more important than ever, and I commend this committee for taking up this important issue of vouchsafing the expenditure of the people's money, and I thank you for that. In April, I testified in a joint hearing of 2 oversight committee subcommittees on the complete lack of reporting, collection, and verification of meaningful data in Medicaid. I underscore what I just said. That's a breathtaking statement. There is a complete lack of reporting, collection, and verification of meaningful data in Medicaid. The same is not true for Medicare. That's why this is a bipartisan issue, and one that we hope will focus on helping the needs of the poorest among us in the United States who must have these program monies in order to survive. The staff report from that hearing stated, quote, Minnesota provides a stunning example of how states are failing to properly ensure the appropriate use of taxpayer dollars spent on Medicaid managed care. This is something we are not proud of. In order for states to ensure the appropriate use of taxpayer dollars, they must be able and willing to collect the data that shows how much is paid in a claim, for what, and to whom. That's only basic common decency. Since the investigation into Minnesota Medicaid fraud has unfolded, several implicated parties have begun to offer up excuses. According to the Trade Organization for Managed Care Organizations, the Department of Human Services actually has the data, but not the ability to analyze it. They say the state's computer system is too antiquated. But in contradiction to this, a DHS assistant commissioner said the data is, quote, literally analyzed by DHS on a daily basis and has been for years. So now either the trade association representing the health plans is fudging or DHS is. We need to find out who. It's our job to immediately get to the bottom of this, and I thank the committee for what you're doing. CMS is already tasked with identifying patterns or instances of fraud and abuse in Medicare and Medicaid. That much we know, and that much is good. But despite that, they require no documented data. Now, the two don't go together. You can't do your job if you don't have documented data. That is why this month I am introducing a bill that will hold CMS accountable to ensure stated audits are conducted properly. That's why this is totally bipartisan, a bipartisan bill. We just want to know where the people's money is going, and is it going to help the poor people in this country who need these services. But because this situation needs immediate attention, I'm proud to announce that I'm sending a letter today to CMS calling for an immediate third-party independent audit of Minnesota's books. We can't allow taxpayer dollars to flow without proper record-keeping ever again. Thank you again to the committee for your fine work, Ranking Member Towns, and also for your fine work, Chairman Platts. I am thrilled to be a partner with you in this important work that you are doing, and I yield back.
Thank the gentlelady for her opening statement and her involvement and interest in the issue, as well as your focus on the efforts in Minnesota specifically in seeking to make sure we do right by all of our taxpayers in Minnesota and across this great nation. All members will have 7 days to submit opening statements and extraneous material for the record, and will now proceed to our panel of witnesses. And we are delighted to have a group of distinguished public servants with us who bring a wealth of knowledge to our hearing today. First, we have Dr. Peter Budetti, who is Director of the Center for Program Integrity at the Centers for Medicare and Medicaid Services, Ms. Ann Maxwell, Regional Inspector General for Evaluation and Inspections in the Office of the Inspector General for the Department of Health and Human Services, as well as Ms. Carolyn Yoakum, who is Director of Health Care for Medicaid at the United States Government Accountability Office, and Ms. Kathleen King, Director of Health Care for Medicare at the United States Government Accountability Office. We thank all of our witnesses for being here with us today. Pursuant to committee rules, if I could ask all four of you to stand and raise your right hand and allow us to swear you in before your testimony. Raise your right hand. Do you solemnly swear or affirm that the testimony you are about to give this committee will be the truth, the whole truth, and nothing but the truth? Let the record reflect that all four witnesses answered in the affirmative. We appreciate the extensive written testimony you provided us and what I call my homework and preparation for our committee hearings. And your doing so certainly allows both members and staff to be better prepared to have a good engagement here today. With your oral testimony here today, if you can seek to limit yourself to roughly 5 minutes, you'll see the light system in front of you. If you do need to go over a little bit, that's fine. But for the purpose of allowing members to get into an exchange and Q&A with you, we'll try to limit it to 5 minutes. And Dr. Budetti, we'll begin with you.
Thank you, Mr. Chairman, and thank you, Chairman Platts, Ranking Member Towns, and members of the subcommittee for this invitation to discuss the Centers for Medicare and Medicaid Services program integrity efforts for the Medicare and Medicaid programs. As I describe in my detail in my written statement, the Administration has made important strides in reducing fraud, waste, and improper payments. And I draw your attention to this chart, which I hope is in a font that at least some of us in the room can read, which illustrates the framework within which we have taken action over the last 2 years. The first point is moving beyond a pay-and-chase approach by focusing new attention on preventing fraud. We're adopting what we call a twin-pillar approach, building upon the traditional program integrity efforts that focus on detecting and prosecuting fraud. We've implemented an approach that involves 2 pillars. One is what we're calling the fraud prevention system, which applies predictive analytic technology on claims prior to payment to identify aberrant and suspicious billing patterns. And the second pillar is the automated provider screening system, which focuses on identifying ineligible providers or suppliers prior to their enrollment or revalidation. These innovative new systems are designed to work together. They're growing in their capacity to protect patients and taxpayers from those intent on defrauding our programs. They represent an integrated approach to program integrity, preventing fraud before payments are made, keeping bad providers and suppliers out of Medicare in the first place, and quickly removing wrongdoers once they are detected. These complement the traditional program integrity activities which continue. Second, we'd like to emphasize that our work is on a risk-based approach. We are not approaching this on a one-size-fits-all model. For example, in addition to the detailed assessment of credentials and other requirements that all providers and suppliers undergo through the automated provider screening system, we've identified those in a moderate level of risk who are now required to also undergo site visits, and those in the high level of risk who will be subject to fingerprint-based criminal background checks. Fraud prevention system itself, the way it operates, represents another example of our risk-based approach. It targets our investigative resources to suspicious claims and providers, generates alerts in priority order, allowing our program integrity analysts to investigate the most egregious or suspect aberrant activity. Third, innovation. For the first time in the history of the program, CMS is using a system to apply advanced analytics against Medicare fee-for-service claims on a streaming national basis. This has enabled us to identify schemes operating across Medicare Parts A and B claims and across the country. The fraud prevention system aggregates A and B data claims in near real time, and this has revolutionized our approach. For example, our investigators formerly had to check multiple systems to determine whether a beneficiary had ever visited the doctor who billed Medicare for services and supplies We've now consolidated dispersed pieces of claims data, beneficiary visits with a doctor or orders for durable medical equipment, and hospital and other providers and other services provided under Part A, enabling our investigators to automatically see the full picture. Similarly, in the second pillar of our approach, the automated provider screening system, this is another significant advancement and innovation. We're using advanced technology in a way that we are committed to both rooting out and screening out the bad guys while making it easier for the legitimate providers to enter the Medicare program. We expect that our enhancements to the Medicare enrollment system will speed up the time for legitimate providers to get in, and our screening processes will keep out the bad ones. The fourth point, transparency and accountability, which are high priorities for this administration. We've held a number of regional fraud prevention summits around the country with a wide range of stakeholders and the general public, and we have engaged in a number of efforts to make sure that the public is aware of what we are doing to combat fraud and how they can join with us in doing that. We are engaging the public and private sector more extensively. For example, we conducted a month-long Fraud Prevention Awareness Month in concert with the California Medical Association and the State of California, and we've involved the private sector, especially the medical community, very closely in our remodeling of the enrollment system to address needs that they themselves have identified. And finally, on coordinating and integrating the program integrity programs. When Secretary Sebelius created the Center for Program Integrity, she brought together the Medicare and the Medicaid program integrity activities for the first time. This has provided a strong basis now for communication between the programs and for aligning as much as possible the fraud policy, anti-fraud policies and procedures across Medicare and Medicaid as required in many cases by the Affordable Care Act. Mr. Chairman, Medicare and Medicaid fraud, we agree with you. They affect every American by draining critical resources and contributing to the rising cost of health care. We've made a firm commitment in this administration to rein in fraud, waste, and improper payments. We have more tools than ever to move beyond pay and chase and implement strategic changes in pursuing and detecting fraud, waste, and abuse. I look forward to continuing to work with you as we make improvements in protecting the integrity of the Federal health care programs, and I very much appreciate your interest in our doing so. Thank you for this opportunity to speak with you.
Thank you, Dr. Budetti. Ms. Maxwell.
Good morning, Chairman Platts, Ranking Member Towns, and other distinguished members of the subcommittee. Thank you for the opportunity to testify about the Office of Inspector General's evaluations of two national program integrity efforts, the National Medicaid Audit Program and the Medicare-Medicaid Data Match Program, typically referred to as MEDI-MEDI. Our evaluations reveal that these national integrity efforts in many ways resemble a funnel. Significant Federal and State resources are being poured in, but only limited results are trickling out. Both national efforts are required to identify improper Medicaid payments for recovery. The National Medicaid Audit Program strives to do this within states and across states. MEDI-MEDI attempts to detect overpayments in Medicaid and Medicare by matching the data across programs to identify suspicious patterns. However, both programs had limited success in achieving the goal of identifying Medicaid overpayments. As a result, both programs had a negative return on investment. In 2010, the National Medicaid Audit Program paid contractors approximately $32 million to identify Medicaid overpayments of just half that amount. In fact, we discovered that 81% of the audits assigned in the first half of that year did not or are unlikely to find overpayments. MEDI-MEDI also had a negative return on investment. MEDI-MEDI was appropriated $60 million over a 2-year period, during which time it saved $58 million. Of that amount, only one quarter, $11 million, was recovered on behalf of the 10 states that were participating at the time. The benefits of the Medicaid program were so minimal for 2 states that they opted to withdraw from the program. One of the states that withdrew from the program stated that it saved $2,000 after investing $250,000 of state funds. There are a variety of challenges that limit the potential of these programs to detect Medicaid overpayments, including issues with Medicaid data, poor program administration, and the lack of contractor accountability. The most fundamental challenge is the data. National Medicaid data are not current, they are not complete, and they are not accurate. In fact, the data does not capture all of the elements necessary for the detection of fraud, waste, and abuse. Due to these data problems, the National Medicaid Audit Program wasted resources auditing potential overpayments that were not real. They were merely mirages created by the data. Due to these data problems, Medi-Medi does not have Medicaid data suitable for automated matching with Medicare data. CMS has said this matching will not be possible for a number of years. In addition to these data challenges, CMS's administration of these programs was flawed. The National Medicaid Audit Program states suffered from inefficient communication between contractors and states that resulted in a duplication of effort. Medi-Medi suffered from a lack of focus on Medicaid program integrity at the federal level. CMS also did not always hold contractors accountable for performing each of their tasks outlined in their statement of work. Our evaluations raise questions about the overall effectiveness of the National Medicaid Audit Program and Medi-Medi. We recognize that CMS has taken steps to improve these programs based on recommendations from the OIG, from GAO, and CMS's own internal assessment. We recommend that CMS continue to evaluate the goals, the structure, and the operation of these programs to determine what aspects should be part of a national strategy to protect the Medicaid program. Further, we believe that more must be done to overcome the significant shortcomings in the Medicaid data. Without timely, complete, accurate, and standardized Medicaid data, it is impossible to effectively detect systemic vulnerabilities that span across states and into the Medicare program. Thank you again for the opportunity to present this work and to be a part of this discussion. The OIG shares your ongoing interest in program integrity, and I'd be happy to answer any questions that you might have on this topic. Thank you.
Thank you, Ms. Maxwell. Ms. Yocum.
Chairman Platts, Ranking Member Towns, and members of the subcommittee. We are pleased to be here today. I'm pleased to be here today with my colleague Kathleen King as you discuss program integrity in Medicaid and Medicare. Our prior work has shown that CMS continues to face challenges with fiscal management of these programs, which have some of the largest estimated improper payments in the federal government. Both are on GAO's high-risk list, in part because of concerns over improper payments. Our remarks today are focused on CMS's progress and important steps that remain to be taken from the perspective of 4 key strategies and recommendations that have been identified in GAO's work. First, strengthening provider enrollment standards and procedures to help reduce the risk of enrolling entities intent on defrauding the programs. Second, improving prepayment controls to ensure that claims are paid correctly the first time. Thirdly, improving post-payment review and recovery of improper payments. And fourth, developing a robust process for tackling identified program vulnerabilities. With regard to Medicaid, since 2007, CMS has monitored states' provider enrollment standards and procedures through comprehensive reviews of states. Within CMS's most recent comprehensive reviews, we found 230 instances of noncompliance with federal laws or regulations related to states' provider enrollment standards and procedures. CMS continues to develop better controls to detect improper claims before they are paid. In this area, the agency has initiated discussions with and provided guidance to states in anticipation of new analytic tools that can identify potential vulnerabilities before, rather than after Medicaid claims are paid. Regarding post-payment claims review, the importance of coordination with states has grown because of the increased number of entities conducting audits, including implementation of recovery audit contractors, or RACs. CMS's shift to collaborative audits with states should help avoid duplication of Federal and state audit efforts. That said, CMS has not established a robust process for incorporating RAC-identified vulnerabilities in state corrective action plans. CMS requires state Medicaid agencies to have a corrective action process as part of their activities to reduce their Medicaid error rates, and information from the Medicaid RAC program could be incorporated into these processes. For Medicare, the Patient Protection and Affordable Care Act authorized CMS to implement several actions to strengthen provider enrollment. Some of these actions, such as developing a final rule on screening providers and suppliers, have been completed. But other actions, such as implementing relevant statutory provisions and some of our prior recommendations, remain incomplete. Our prior work found certain gaps in Medicare's prepayment controls, and we made recommendations for improvements, such as adding controls to identify unusually rapid increases in medical equipment billing. We are currently evaluating CMS's efforts in this area. CMS has also taken steps to improve its post-payment reviews and recovery efforts. In March 2009, the agency began the National RAC program for Medicare fee-for-service. As of May 2012, the agency reported that just under $2 billion was recouped due to these contractors' efforts. While CMS has implemented a RAC for its prescription drug program, it has not done so for its Medicare managed care plans. Lastly, our March 2010 report on CMS's RAC demonstration program found that CMS had not established an adequate process to ensure prompt resolution of identified vulnerabilities. We recommended that CMS do so, and we are currently evaluating the steps the agency has taken to develop such a process. While CMS has made efforts to improve program integrity, further action is needed. We believe that many of the lessons learned from our work on Medicare could be applied to strengthen the Medicaid program, as CMS and the states begin to use the additional tools provided through recent legislation. Effectively implementing provisions of recent laws and our recommendations will be critical to reducing improper payments and ensuring that Federal funds are used for their intended purpose. Mr. Chairman, this concludes our prepared remarks. We would be happy to answer any questions you or other members of the subcommittee may have.
Thank you, Ms. Yocum. And Ms. King, I understand that Ms. Yocum was speaking for both of you. Okay. Thank you. I'll now yield myself 5 minutes for the purpose of questions. Again, thank each of you for your testimony and your insights, and look forward to not just today with this hearing, but in going forward to continue working with each of you in your respective offices as we collectively try to do right by the American people and how their dollars are used. Dr. Budetti, I'd like to start with you. And in your written testimony here today, you talk about kind of the traditional approach, and then, as you highlighted, a new approach. And your written testimony certainly focused extensively on new efforts, the fraud prevention services, the automated provider screening process. And the way I looked at your written testimony is kind of you mentioned the more traditional, the National Medicaid Audit Program, the Medi-Medi program, but you really didn't go into a lot of detail on that. Should I take from that there's some maybe acknowledgement or understanding that the findings of the Inspector General GAO of the previous programs or the older programs focused on program integrity have not been as effective as we'd like, and that you're devoting more focus and resources on a new approach, the FPS and the APS?
Short answer is yes, at least to the acknowledgement of the problems. You may or may not be surprised to know that I find very little to disagree with in much of what you've heard by way of testimony from the GAO and the Office of Inspector General. The current leadership, I'll just focus on the Medicaid integrity programs, the National Audit Program for a second, because I think that is where some of the most difficult problems have been identified. The current leadership of that program took over in late 2009, and the program came into the Center for Program Integrity in early 2010. It was during that year that we identified internally that we were getting the wrong kinds of results, very limited results from the way that we were going about doing the national audits, and we both embarked on a program to develop a new approach and also to cut off the old approach. So the life history of the audits that were initiated being based on the inadequate data that you've heard described, they started in September of 2008 before we took over the program, and the last one, my information is, went out in February of 2011. During that time, so we've not sent one out since then. That's my understanding. And since then, we have been building a new approach which involves working more directly and more collaboratively with the states, because the states do have, although they have it in very different systems in some cases, and it's not completely easy to get access to, the states do have, of course, much more complete information than we've been getting at the Federal level. So we've engaged with them in, thus far, I understand, 137 collaborative audits. Those are taking place in states that represent about 53% of all Medicaid expenditures, and we're looking to expand that substantially over the coming year. So we do acknowledge that there have been problems with the National Audit Program, and we initiated corrective action early on, and we're very much dedicated to improving that program.
Specifically on the approach, on the traditional approach and acknowledgment of the problems there, one that came out in the Inspector General's testimony and written testimony was the example between the disparity between the review integrity contractors and the audit integrity contractors. And one example highlighted in that testimony was that the review contractors identified 113,000 providers with potential overpayments of $282 million. And then when the audit contractors went in and got into that information, there was only 25 of these 113,000 were determined to have been given overpayments, and only $285,000 actually found to have been inappropriate versus the $282 million. I mean, that's quite a disparity, and shows a significant problem with that approach.
That's exactly right. Those are the kinds of numbers that caused us to stop that approach and that have caused us to look to a new way of doing business. One of the things that kept that going was that when the review contractors looked at the inadequate data, they made projections that looked very promising. And it wasn't until we found out that they, in fact, did not return any results when we went out and conducted the actual audits that we decided that this was so problematic that we would stop that and we would have a new approach. In the meantime, the Federal Government, as you've heard, does not have yet all of the data that are necessary for us to do the audits ourselves, and so we believe that for now the best way to go about this is to build up the collaborative audits, working closely with the states who do have the proper data.
A quick follow-up before I yield to the ranking member on that. So today, are we still paying any review audit contractors going forward, or the audit integrity contractors under the old system?
So we have existing contracts. We have some audits that are out there that have yet to be completed. And we are, at this very moment, we are looking at the restructuring of our entire audit program so that we can use those resources in a much more effective way. And that also will tie in, if I have time later, I can talk about how that we're exploring how that will tie into the use of our Medi-Medi resources as well.
Yeah, that's a concern of those existing contracts and what we're paying out still, when clearly the results versus a collaborative approach and the new systems is night and day.
We're directing them to new tasks that are still within the scope of their existing contracts, and we're exploring the way of, and we're exploring how to completely restructure our approach.
Great. Thank you. Now yield to the gentleman from New York for the purpose of question.
Thank you very much, Mr. Chairman. And let me just begin by saying I'm impressed that there's collaboration with CMS, with the Inspector General's Office and Department of Justice and law enforcement, in recent years, which I understand has resulted in more than 600 criminals being successfully prosecuted for fraud against Medicaid and Medicare, and more than 500 of whom are serving prison sentences of over 42 months. How many were indicted? I'm trying to get the conviction rate. Would anybody know? In terms of that number, how many actually indictments? I'm sorry, you turn your mic on?
That's work that we're currently conducting, and we'll have the answer to that later this year.
Okay, well, we'd like to get that information.
Both on the civil and the criminal front.
And the reason I raised that is because the Inspector General indicated that there was a situation where you spent $250,000 to collect $2,000. I just think we need to look at every area to make certain that there's just not waste, fraud, and abuse. Let me ask, do you think is that the fact that these systems do not talk to each other? I mean, what is the problem? And as the chairman mentioned early on, this is not one of those committees where we got you. We want to help. We recognize how important it is today more than ever that we save money and make certain that it's being used and used properly. So we want to be helpful. But is it the fact that you do not have the money to put the system in place to be able to get the information that is necessary to be able to adjust? And let me just say why I raised this question. I was in bed one night, and at 1:30 in the morning, I get a call from American Express. Said to me that somebody was making a big purchase in the bar on my credit card. And they said they hated to bother me, but the point was that this was so unusual. I guess because my bar bill is like $5, I guess. I don't know. But I'm not sure as to why it was so unusual. But anyway, the point was that they reached out to me to make certain that there was no fraud. I mean, they wanted to make certain that they took care of it right away. I mean, why can't we look and find a technique, a method to be able to do the same thing? Dr. Buccetti.
Mr. Towns, I'm happy to report that under our new fraud prevention system, since as of the end of April, our investigators have conducted 1,541 interviews with beneficiaries that really are parallel to the call that you got, unfortunately, in the middle of the night from American Express, where we check to see whether or not beneficiaries can confirm that they have received the services that they may or may not have received. So that's very much built into part of what we're doing now.
How long has that been in place?
This system went in place at the end of June of last year, and so as of April of this year, we've counted 1,541 such interviews. On the broader question of resources, we're very grateful to the Congress for the resources that have been provided. As you know, the President has also asked for some additional resources in this area. I think that at the Federal level, we have had very good access to the kinds of data that we need, and it's a question of putting the systems in place to deal with the information that we generate properly. I think a lot of States would tell you that they do face some resource constraints, notwithstanding that a lot of their expenditures would be covered by the Federal Government, and so there's some ongoing discussions with States about that as well.
I think my question is it the fact that you do not have the kind of resources that will make it possible for you to put a plan in place that will help you to be able to evaluate and to see in terms of what's really going on? I sort of get the feel that that the technology and the system is not in place to do that. And I know it takes money to do that. And sometimes I think that instead of putting the money in, we just sort of try and make do, and then we end up spending more by trying to make do.
We're very pleased that under the Small Business Jobs Act of 2010 and also under the additional funding that was provided in the Affordable Care Act, that we have very substantial resources. The Small Business Jobs Act is what specifically called on us to go ahead with what we were intending to do, which is to put into place the advanced technologies that I was talking about, the fraud prevention system. And that is in place, and it's been up and running now since the end of June of last year. So we believe on the Medicare side, we have the technology, we have the systems in place. They're going to grow and continue to grow and become more and more sophisticated over time. So I think that on that side, I think we're in good shape. I do think we face a challenge that we're facing up to of translating that advancement on the Medicaid side.
Mr. Chairman, I see my time has expired.
Okay. Thank the gentleman. Now yield to the gentleman from Oklahoma, Mr. Lankford.
Thank you, Mr. Chairman. And I would say to the ranking member, I'm very pleased to hear that the pastor, it is rare for him to be in a bar late in the evening, so much so that American Express calls him and says it's a rare event. So glad to be able to hear that. Let me bounce a couple of questions off of you as well, and I have some real concerns on the RAC audit process. If there's any one thing that I hear from hospitals, providers, and folks the most, it is the full-body cavity search that has become the RAC audit process. I have several concerns. One begins just with the process of it. As a Federal Government, we are designed to serve the people rather than them serve us. And the RAC audit process seems to put the whole process on its head, that they exist there to serve us and we're going to stay long enough until we find some fraud. The contingency fee process part of it, my fear is turning this into a bounty hunter process, that we have outside contractors that are coming in and they're going to stay until they get paid, until they find something there. That moves the system significantly towards we're going to find more fraud, but it also moves the system significantly towards a hostile, not helpful environment in that. Saying all that, that's where we are, I feel. I don't know if anyone disagrees with me on that. I've yet to find anyone that disagrees with that, and I've had multiple conversations with that sense. If you've got a disagreement, I'd like to hear it, but I'd also like to hear how are we preparing people for these RAC audits and what process is occurring currently, so when people arrive, it is an environment where we evaluate, as we should. We should hold people to account, but this should not be a hostile event.
Representative Lankford,
Yes, ma'am.
as you may know, the RAC program started with a demonstration,
Right.
and we evaluated that demonstration, and we did find a number of areas for concern. And there were some missteps on the part of CMS in terms of the issues that were explored there and, perhaps over-aggressiveness. And I think that CMS, in implementing the national program, took a lot of those concerns into account, and they devised a system at CMS where all of the central players in the operation would get together and agree on what kinds of situations the RACs could look into, rather than having them just go out on their own. So in the national program, I think that part has been smoother.
Still paying people a contingency based on what they find.
That's the way the program was set up.
That's the way it's set up.
To pay on contingency. But one other thing I might add about that is the RAC program is designed to identify overpayments and underpayments, and it's not specifically designed to look for fraud. Right. It's really looking at cases in which the agency has paid too much or too little.
Right, but a lot of the underpayment, what do we have, a 4% national rate for underpayment?
The vast majority are overpayments.
Yeah, they're really going and looking for overpayments, obviously, on that. And that it becomes an issue of what is an overpayment and how complex this is. My assumption is it's typically we overpaid you because we shouldn't have paid you at all for this, because we disagree you shouldn't have had them in the hospital 2 nights, or we disagree this shouldn't have been an overnight stay at all, or this procedure or this coding. So agree or disagree on that?
I agree, but they are following Medicare policy when they're doing the audits.
When the hospital responds back to it, when there's been a denial, my understanding is there's about a 75% rate of turning that over. Am I correct or incorrect on that?
When we did our work, we didn't have the information about what the overturn rate is.
Well, the appeal rate seems to be extremely high. When we're looking for fraud and we're fighting back and forth on whether this should have been through the process or not, whether it should have been a 1-night or 2-night or overnight at all or whatever it may be. and then they appeal it and have a 75% appeal success rate, that tells me there's still an issue. There's still a problem hovering out there somewhere that we've got to be able to resolve, because we are creating a hostile environment with providers. This is someone we should be serving. We should hold people to account, but we should also be serving them rather than creating an environment where they're spending tens of thousands to hundreds of thousands of dollars defending something that was valid.
You know, we haven't looked at the implementation of the national program, so I really don't know there whether the appeal rate has gone down, and we did not have access to the appeal data during the course of our work. So you're raising valid concerns, but I don't know the answer.
Okay, Mr. Brighetti, you look like you were going to say something.
Yeah, if I would, I would just add a couple of things to that. One, I would echo what Ms. King said, but I would also add that CMS is listening to those kinds of concerns that you've identified. We've certainly heard them as well. We have put into place a demonstration project in order to work with hospitals when there's a question as to whether or not the patient should have been an inpatient or an outpatient, and set up a demonstration where hospitals can rebill if that's the determination, so that they don't lose the entire payment as they have under standard operating procedures that have been in place. We're also very much looking at all of those concerns, and they're the matter of a great deal of internal discussion in the agency at this time.
Well, I would encourage you to keep it as a matter of a great deal of internal discussion so we can try to evaluate it, because this obviously is an issue. I know this is a project you're trying to launch on it, but we've got to be able to resolve this. With that, I yield back. Thank you.
Thank the gentleman. Now yield to the gentlelady from Minnesota, Ms. Bachmann.
Thank you again, Mr. Chair, and also Ranking Member Towns. One area to look for fraud is with the Medicaid providers, and others with the Medicaid or the managed care organizations. And this would be a question for Dr. Bedetti, if you will. And just briefly, based on the concerns that the managed care organizations are using Medicaid premium dollars to cross-subsidize other non-Medicaid state health plans, could you tell the committee what data you're gathering to combat these allegations, if any?
So, Congresswoman, I think that you're aware that in your state, in Minnesota, that after discussions with CMS that have been ongoing recently, that Minnesota has recently agreed to repay to CMS the appropriate federal share of the amount of money that was contested. And we're currently reviewing the state's submission on that matter, and have every intention of collecting the appropriate federal share. We are also looking
But if I could ask Dr. Bedetti, how are they coming to the conclusion of what number? Because my question is about what data are you gathering so that we can be confident that states aren't taking Medicaid dollars and then using them for a cross purpose to subsidize a non-Medicaid, non-federal Medicaid state health plan? What specific data are you asking the states for so we can be assured this isn't going on?
I think that that question is very well taken. I think that we need to continue to build our capacity to collect the appropriate data on managed care operations.
So we aren't collecting any data to that effect today.
The emphasis has been on the fee-for-service side. I agree with you on that.
So we need to do better, it sounds like.
We do need to do a better job in terms of getting that degree of oversight, and we are engaging in doing that.
And I agree. I think that shows a big hole that we have because we're not even asking the right questions. And I think that goes to Ranking Member Towns. The right question was asked of him at 1:30 in the morning. That's what we need to be doing, asking the right question. Clearly, we're not. Let me ask you also, Dr. Bedetti, since 2006, CMS has now spent over $100 million developing the One Program Integrity System to merge Medicare and Medicaid data. And the Medicare data has been collected, but to date, the Medicaid data has not been included. Now, this is significant. It's been 6 years. Why is that the Medicaid data is not included? And what role should the states play in, or are they perhaps in delaying the collection of this data? And are states withholding information from CMS?
We certainly recognize that the data that we have been getting from the states are not adequate, and that's been at the core of our restructuring of the National Audit Program. We've been working very diligently over the last couple of years to improve that situation and to get the right kind of data. There's a demonstration project going on with 10 states that's designed to look at the data that we're currently collecting, to identify the data that we do need to do proper oversight, and as well as a number of other program operation requirements at the Federal level, and then to get those data from those 10 states and to use that as a model for improving the flow of data from the states.
Well, I would agree, but that doesn't answer my question why for 6 years we have Medicare data, but we don't have Medicaid. There's just an absence. So the question is the state holding out on us? Are they not giving the data? Are we not holding them accountable? So if you could get back to the committee and answer that question. I just have one question for Ms. Yoakum, if you could answer that also in the brief time I have. The GAO lists Medicaid as a high-risk program, and GAO has previously issued reports that address CMS's lack of oversight into Medicaid managed care rates. So given that we have 3/4 of Medicaid beneficiaries enrolled in some form of managed care, could you speak to the data that's used by GAO and CMS to address this aspect of Medicaid?
Certainly. Right now, one of the big issues across the Medicaid program are the different data systems and the extent to which they actually talk to each other. There are two different ways that managed care data may be collected. One is through its expenditure system. The second is through a separate accounting system that looks at the managed care reporting itself. Our work that we looked at on actuarial soundness and Medicaid managed care, we ended up going back to state plans and to state contracts with managed care plans in order to understand CMS's review and oversight in that area.
And Mr. Chairman, I thank you for indulging me to be with the committee. It seems to me that there's a real problem in that we aren't asking the right questions. And I think we'd be a lot farther down the road if we ask the right questions. That's the purpose of my legislation that I'll be introducing shortly. But I thank the committee so much for graciously allowing me to be here today. And I thank Dr. Bedetti for getting the answers to the committee to the question that I asked.
I thank the gentlelady and Dr. Bedetti. If you would follow up in writing to the committee for the record in response to Representative Bachmann's questions. And I think the focus that you've touched on here and Ranking Member and I were speaking about is so important that unless we have that data, we really won't be able to get to the root causes. And what I talk about internal controls, ultimately our goal is to get to the root causes of the improper payments, the fraud, the misuse of funds. But without the data, it's hard to know exactly where that is. So that focus, especially on the Medicaid side, is going to be so important to ultimately reducing the improper payment numbers for both Medicaid and Medicare. So I thank the gentlelady for participating. Now I yield to the gentleman from Virginia, Mr. Connolly, for 5 minutes.
I thank the Chair. And I might ask my colleague who's joined us and welcome her to the subcommittee. She indicated that we're not asking the right questions. Because I'm late, if you would indulge me, what, pray tell, is the right question?
Well, I think the question is we want to have an independent third-party audit of where the payments are going. Today.
You mean the improper payments?
Thank you. That's a better way to phrase it, and I thank you for that correction for the gentleman. We have not conducted for decades independent third-party audits of the states. We aren't asking the meaningful data. In our state of Minnesota, for instance, a bill has been presented from managed care organizations to our state of Minnesota. The state pays it. It's almost like if you went to the grocery store and you had maybe what you thought was $35 worth of groceries in your grocery cart, and then the cashier said, please give me $300. And you said, well, let me see the grocery tape so I know what I'm paying for. And the cashier says, no, I'm not going to give you the grocery tape. Give me $300. We at the Federal Government aren't demanding the itemized statement of what the managed care organizations are charging the states, and then the states are passing that bill on to the Federal Government.
I thank my colleague.
We're just paying it. So thank you.
Thank you very much. Appreciate it. Dr. Bedetti, maybe start with you. What's your response to our colleague's concern, certainly with her home state of Minnesota, and I'm sure other states as well, this idea that I'm paying $300 and I can't get the itemized bill to justify why I'm paying $300, for example. Is that applicable?
We have acknowledged that the existing data that are reported by the states in this area to the Federal Government have proved to be inadequate for conducting Federal audits. I would point out that there's two ways to think about this. One is the Federal Government gets the data and does the audits or has people do the audits. The other is the Federal Government works with the states to make sure that the right data are available and works collaboratively with the states to do the audits. The first model has not proved to be workable with the data sets that the Federal Government has been getting. We're working to improve those data sets. We're not abandoning that approach. We're working very hard to improve them. But in the meantime, we know the states do have the data, and so we are embarking on a new approach with collaborative audits so that we will use our resources with the states to audit the data that are in the states. So we're approaching it from both sides. We don't want to wait until some future date when the Federal Government has perfect data from the states. We need to keep an eye on things right now, and that's what we're doing with the states.
Could I ask, given the, Medicare, we're talking about Medicare?
So for Medicare, of course, the Federal Government has the data. But for Medicaid, we don't have the data. The states do.
But Medicaid's not a new program.
No, sir.
And obviously the problem did not occur only in this administration's watch. But why is it taking us so long to sort of figure this out and try to figure out systems to put in place to correct this defect?
My understanding is that the current data set that's collected was designed for the use of the program. It was being used in other ways, and it has not proved to be adequate for the way that we need to use it now. I'm not an expert on the history of the Medicaid Statistical Information System, however, but I'd be happy to get you some background.
I think the subcommittee would appreciate it on both sides of the aisle. Let me ask you this. I'm under the impression that U.S. attorneys' offices are focusing increasingly on Medicare fraud and recovering sizable amounts of money from fraud, from vendors, medical practitioners, and the like. Is that a fair characterization of sort of this administration's decision to crack down on that fraud and trying to recover as much as possible? Ms. Maxwell, did you want to comment on that? It looked like you were getting ready to comment. Oh, all right. Dr. Bedetti?
I'd be happy to yield to Ms. Maxwell, but, sir, there are fraudsters who stay in business after we catch them, and they have assets that we can go after and recover. And in that case, as you know, there have been substantial recoveries in recent years. The most recent year was over $4 billion that was returned from a variety of different approaches. Then there are fraudsters who, of course, disappear as soon as we identify what they're doing. They have no assets for us to go after. We still want to catch them. We still want to throw them in jail if we can. But that's why we need to build that's why we are building our system that's designed to prevent fraud from occurring in the first place, because many of those fraudsters will never recover anything from it.
Right. Mr. Chairman, I know my time is up, and all of us in the subcommittee have been very focused on improper payments under your leadership, but fraud is an important subset, obviously, and making sure we have the focus of the Federal Government and the resources. And I must say, I am impressed that the Obama administration has taken it very seriously, and I think the 99 U.S. attorneys' offices are important allies in this particular component. So the more information I think we could get on that would be appreciated. I thank the Chair.
Thank the gentleman. We'll proceed with the second round of questions and yield myself 5 minutes for that purpose. Dr. Bedetti, you talk a lot in testimony, written and oral here today, about the automated provider screening process. And in your written testimony, you give a number of examples of how it's helping to screen out either new applicants, new provider applicants that are illegitimate, inappropriate, as well as going back and with a goal by 2015 to review all existing 1.5 million Medicare suppliers and providers. When I look at the numbers, and I've tried to, on page 6 of your testimony, combine them, you talk about an initial review that kind of knocked out 13,000 deactivations of providers, and then you talk about an additional round, a second round that knocked out approximately another 10,000, 11,000. If I total those up, I come with up to about 23,000, 24,000 providers in the review of existing, that 1.5 million. And again, from your testimony, apparently there's been about 275,000 existing provider suppliers who have been rescreened. And so if my numbers add up correctly, we're talking 8 to 10% of existing providers and suppliers that when we went back and looked at them, we knocked out for some reason as not appropriate and were eligible for taxpayer funds. If that number, 8 to 10%, is accurate, we're talking 120,000, 130,000 or more providers. If you translate that over 1.5 million, I mean, that's obviously very disconcerting. Am I looking at that accurately, that that's perhaps the scale of the problem we're facing?
So even one would be disconcerting as far as I'm concerned, Mr. Platts. So I would share your concern. I will tell you that we started out with identifying the highest risk providers. So our initial efforts were focused on people that we considered to be the highest risk, and those included people that we had reason to believe were not licensed to practice in the states in which they were eligible for Medicare, or they were not in the national database, they were only in the local systems. There were a number of criteria that we used to identify them. So we started out by running all 800,000 physicians who were in the national database through the automated provider screening system, and to identify the ones who did not appear to be licensed in the place in which they were allowed, in which they had Medicare billing privileges. And so we examined those, and those represented a fair number of the ones that
of that 800,000, roughly, about how many of the 800,000 came back as not being licensed?
It was a fairly significant. I don't have it in front of me, but I'd be happy to get it. I'd be happy to get it to you. We then proceeded to run all 1.5 million providers and suppliers through the automated provider screening system to establish a baseline for future analysis, because we're doing several things. Not only are we in the process of revalidating all 1.5 million providers and suppliers, but we're also in the automated provider screening system putting into place an alert system. And the alert system will tell us between times, not just at enrollment, not just at revalidation, but if somebody dies, if somebody is convicted of a felony that's relevant for our concerns, if somebody loses their license, we will get pop-up alerts to that effect so that we can take action without waiting for the revalidation period. This is all new. Most of what was done in the past was being done manually and was substantially less efficient, I would say. So now, at the same time that we are enrolling our new applicants, because we do get approximately 20,000 new applicants per month to be providers and suppliers in Medicare and Medicaid. In Medicare, we're also engaged in the revalidation process that has gone on, as you've said. So the numbers may be a little different when we've finished with everybody, because we started with the highest risk.
Right. Yeah. So that 8 to 10% probably is high because you were specifically targeting the high risk.
Yes.
But as you say, even if it's 1%,
even if it's one, even if it's
15,000,
right.
yeah, it's still a huge.
We should do something about it.
Yeah,
know about it and do something about it.
Yeah, that use of technology in the screening and the rescreening, and those flags to go up that if there is a delicensing, I think is critical to ultimately getting where we want to be. Ms. Maxwell, in your testimony, you talk about states that had participated with CMS on Medicaid not very effectively, and you referenced 2 states that have withdrawn, and one in particular that in participating in the partnership had only recovered a minimal amount, a couple of $1,000s, but when they withdrew, they recovered about $28 million. Are you able to identify what state that was that withdrew, and how, and what did they do different that, to the best of your knowledge, that was so much more effective?
I am able to identify that state. It is the state of Washington, and it's my understanding that the $28.9 million that they recovered was part of their ongoing state Medicaid program integrity efforts.
Are you aware of what their efforts were that were so different that they succeeded significantly better than in the partnership with CMS?
No, I'm not aware of what they were doing that was different.
Why I ask that is it seems like that's an example of a state that has a good state-based program in place that perhaps with the Medicare Integrity Institute, that CMS, that we would want to look at to try to share that approach with other states. Maybe it will match up, maybe not, depending on the comparison of states, but that we learn from those best practices out there and get that information shared. So, Dr. Burdette, are you familiar with what the Washington State had done and whether that's been looked at to replicate elsewhere?
I can't speak precisely to that, but I can tell you that we have put into place a system of identifying best practices and sharing that among all of the states. We have an active process for doing that, as well as bring people together. We've now passed the 3,000 state employees who have been trained down at the Medicaid Integrity Institute, and one of the activities that goes on certainly is networking and sharing of best practices. If you'd like a little more information on the Washington program, I'd be happy to get it for you. But I do know that we do certainly work our program integrity, our Medicaid program integrity activities certainly have been very supportive for all the states, including Washington.
Yeah, if there is any information that you have available regarding Washington State and perhaps what they did different, that was seemed to be much more effective than what had been done in that partnership, that would be great. I see my time is well expired, so I'll yield to the ranking member for questions.
Thank you very much, Mr. Chairman. Let me begin with you, Ms. Maxwell. Does OIG use any cutting-edge technology tools of its own to help fight fraud?
Yes, the U.S. Office Inspector General has increasingly used a data-driven approach. We have developed our own data warehouse that allows for the collection of data across the Medicare programs, and we mine that. In particular, we have used that approach in our strike force efforts. Since 2009, HHS and DOJ have created rapid response investigative teams in 9 cities around the country, and those cities are targeted through the use of data.
Could you comment on the effective tools that CMS is using in terms of the tools they have in place and that they're using, and the new ones that have been implemented? Could you comment on that?
The study that I'm prepared to speak on focused primarily on Medicaid program integrity, and the tools I believe you're referencing are on the Medicare side, so I don't have any comment on those.
Right. Let me ask you, Ms. Yoakum and Mrs. King, is it necessary to have so many categories of contractors? Can't we consolidate some of the roles and still reach our objective? Of program.
I'm sorry.
Yes.
On Medicare side, since its inception, Medicare has largely been run by contractors. There has been some significant consolidation on the Medicare side. It used to be that there were organizations called carriers and intermediaries that process Medicare fee-for-service claims. They've been consolidated into the Medicare administrative contractors, and now there are many fewer of them. And also the program safeguard contractors have been consolidated up to the same level as the Medicare administrative contractors. I mean, that said, there are still different types of contractors that have specific functions. But, I don't know that that's, it's not something that we've looked at, but I don't know on its face that that would be inappropriate.
Sir, on the Medicaid side, GAO does have some ongoing work that is looking at some of the contractors that are participating in the Medicaid Integrity Group, and that will be out this summer.
Right. Let me ask this. When you make recommendations, are they followed?
Largely. That's something that we keep track of And we go back once a year and we look at that, and I think that our track record is many more recommendations are adopted than not of those that the agency agrees with.
Overall, it's about 80% of our recommendations get acted on by the agencies that we review.
Are the ones that they do not adopt, are they saying that it's a lack of resources?
I think it'd be hard to describe at a global level what the reasons are. Sometimes it may be resources. Sometimes it may also just be that they disagree and they don't believe it is a high enough priority.
Sometimes I think it's conflicting priorities. The agency has a lot of work to do, and we make recommendations, and they are in agreement with them, but they have higher priorities that bump them.
Right. Let me just conclude, Ms. Maxwell, with you. How widespread is the problem of lack of oversight of contractors, and what is the ultimate effect on program integrity?
Well, speaking with respect to the Medicaid program that our reports touch upon, we did find instances of lack of contract oversight by CMS. As I had mentioned, the review MIC was not held accountable to all the tasks in its statement of work. On the Medi-Medi side, the annual assessment of the Medicaid, the Medicare program integrity contractor that runs that program did not actually assess all of the variables in that task order.
See, Mr. Chairman, my time has expired, so you're back.
Okay. Thank the gentleman. Just a quick follow-up before I go to the gentleman from Oklahoma. On that failure to fulfill all the task order, all the requirements, was there any consequences for not doing that you're aware of?
No. What we were told is that at the time, which was early in the program, CMS did not expect that the contracts would fulfill these particular aspects of their statement of work. It's my understanding that they have changed, and they are now holding the contractors more accountable to all the tasks in their contract.
Thank you. Yield to the gentleman from Oklahoma.
Thank you. Let me do a quick follow-up statement. Finish out talking about the RAC audits. I do have a statement from the AMA about the RAC audits I'd like to be added into the record.
Without objection, so
questions and issues that they had as well. Is there a system in place? When you're still with coding and billing, some of those things are automated. Obviously, when they go through an audit, they can get a chance to look at those, and those will bounce up. When I do my taxes, go through a program, at the end of it, it comes back and does a red flag for me on everything to say, okay, double check and make sure this is correct. For providers, they have any system like that so that before someone comes in and does a RAC audit, someone is checked and rechecked locally. This might come up as a question. This is not consistent with typical billing. Is there anything like that that's in place for the providers?
I do know that there are a number of reasons why claims are not accepted the first time around, and providers get information back on the claims. But I really can't speak to that in exactly that point in detail. I don't know if
this is submitted online. It's submitted through a program, right?
Most bills are now. Yes.
Right. That's what I assume. So what I'm asking, is there a way to be able to set that up so it's built so it checks it locally before they ever submit it, that there's a quick verification of that to say, double check, this line was left out, this code seems to be inconsistent with this one?
That's not something that we have ever looked at, but my understanding is that the providers do use software billing programs that would enable them to check for those kinds of things.
Okay. But you're saying that's not something
that we have looked
provide.
At.
They purchase a separate one that actually attaches to that, a third-party software somewhere that does that?
Yes, sir.
Because obviously the goal of this is right the first time, not that we're paying chasing, and not that we're trying to do a RAC audit to be able to come down on someone on that.
Right. Our statement does talk about CMS's efforts on the Medicaid side in this area, looking for prepayment edits. CMS has to date looked primarily just at the process for doing this, not necessarily at the content of the individual edits.
Right.
They have identified some notable practices, some of which sort of stop the claim and identify what information is necessary. So.
And on the Medicare side, we are doing a significant amount of work on Medicare prepayment edits so that Medicare would not pay claims that are not in conformance with its policies or providers who are not eligible. But that's, I think that you were asking a question that, on the provider side, what do they do so that by the time they submit a claim, it's clean?
That's correct. Yeah, the goal is that when it's submitted, it's clean, it's been checked and rechecked, and then they have some confidence that this is going through on it. Ms. Maxwell, I'm very concerned on the data matching, the Medi-Medi program, and your testimony that in previous years we spent $60 million on a program that recouped $57.8 million. That doesn't seem like a real great investment in the process. The question is this a program that can be improved? Is this a program that needs to be terminated? Are there ideas that have been submitted to what to do with it at this point?
The core issue that I bring up in the testimony today is the fact that the program is supposed to be matching Medicare and Medicaid data, and yet it doesn't have the Medicaid data to match. So it's perhaps not surprising that they're not finding as much as they would expect, and certainly they're finding very, very little on the Medicaid side for that reason as well. So to improve that program, and as well as the MIC program that we talk about, really it goes back to the Medicaid data. We absolutely need national standardized Medicaid data to make these programs worthwhile.
Is there a reason that the Medicaid data can't be standardized to the Medicare data as far as how it's drawn in from a provider? Obviously, most providers do both anyway, but those systems can't be consistent.
Just to engage this a little bit, Mr. Langford, the Medi-Medi program operates on a state-by-state basis, so that the contractors who are actually the Medicare investigative contractors work with the state. And as I said before when I was talking about expanding our collaborative audits, we believe that this is a framework that we can use for enhancing our ability to work with the individual states. We have some 15 states now representing well over half of all Medicaid expenditures that are in the Medi-Medi program. A couple of those states have recently, one in particular, we believe has recently shown that with appropriate use of the Medi-Medi approach, it can have very substantial returns. And so we believe that this is a way for us to build out part of our collaborative approach with the states, because of being on-site with the states, working directly with them, and engaging them with both the Medicare and Medicaid data.
So what is an appropriate return? Obviously, spending as much as you get back in is not an appropriate return.
No, the return that we're seeing in more recent times is much higher than that. I don't have the numbers in front of me, but I'd be delighted to share them with the committee, because we believe they're very positive. But we think there's more to do. There's definitely still more to do.
Okay. Thank you for that. I yield back.
Thank the gentleman. I have just a couple final questions. I want to try to get in the record, and then apologize. I've got a markup going on down the hall in Ed and Workforce, and have amendments I need to get there to offer. But a quick follow-up on the Medi-Medi issue and the state's compliance or provision of data. Ms. Maxwell, in your testimony, you referenced that while there is Medicare Part A, B, and D information in, when it comes to Medicaid, the projected time frame is another 3 years, 2015. And Dr. Guidetti, would you agree with that projection? And if so, why another 3 years before, that's 3 more years of lack of information to act on to prevent fraud and improper payments?
Our current target is 2014, not 2015, I believe, for the full, for getting the Medicaid data into the integrated data repository, which then is accessed through the 1PI system.
Right.
But I agree with you that we can't just sit and wait for those data to be available. That's why we have our pilots underway to identify the best way to do this and to get states actively pursuing doing this, and why we're also engaging the states in a hands-on collaborative way, so that we're not just dependent on the data that flow to us.
Right. Is there a point where, and maybe you're already thinking of this or looking at this, where you look at the Medi-Medi system and IDR versus your FPS and your APS systems that you've now put in place, and say, listen, we just got to cut our losses and move on to what is apparently appears to be more effective as opposed to trying to fix what's been going on for years in these older systems?
Thank you for raising that question, because that's actually very important aspect of the fraud prevention system, is that it involves streaming data, live data. It's as if you were, I don't know, looking at all of the publications that were coming out every day and screening through them for certain problems, whereas the IDR is more like the Library of Congress that has all of the reserve data in it, which is extremely important for a number of purposes, not just program integrity purposes, but a number of different activities in CMS depend upon and use the IDR. But the IDR is also the warehouse, the data warehouse upon which our models for the fraud prevention system are based, because if you have 5 or 6 years worth of data, we can build very sophisticated models, and then we put them into place to catch the streaming data on the fraud prevention side. So the two go hand in hand. One is not replacing the other. In fact, they're very much a combined approach, and both are extremely relevant. The IDR is in very, for many aspects of it, is an extremely valuable tool that gets more important all the time.
So if you get that state data in there on the Medicaid side, IDR, all the more effective the traditional approach is going to be to allow that one PI system to better work, but also your new approach,
yes,
and developing those analytics, to really say, what's the pattern of fraud that we then try to put in those flags, in going forward.
That's exactly right. They're intimately related. The one is kind of the cornerstone of the other. It also allows us to test the models ahead of time before putting them into place by looking at historical data.
Great. I won't be in this chair a year from now or 2 years from now, where hopefully all this is more fulfilled. Whether that's a colleague on my side of the aisle, I'm biased that we stay in the majority, or Mr. Towns returns to the chair, as he and I have switched positions here a number of times, remains to be seen. But I'm certain, whether it's under the leadership of Chairman Issa and the full committee, or Mr. Towns on the Democratic side, the importance of these issues are going to continue to be looked at by this subcommittee, whoever is in this chair. And we certainly want to have success in going forward. A final question, and I've got probably 12 more I'd like to ask, but not the time to do so. And I'm going to conclude with, I'm going to say 2 quick ones, and I'll say quick. But first is, Dr. Pudetti, with getting that state data in, the way I read it is there are regs and requirements in place that the states have not adequately complied with as far as providing the data that they're supposed to. Is that a fair statement? And if so, what, if any, consequences have been threatened to the states to help ensure compliance? Because we're giving them one heck of a lot of money, and if they don't want to comply with what we think is necessary oversight and protection against fraud and misuse, they need to understand that they can't just continue on.
So the states have been cooperating with the existing request, which constitutes the Medicaid Statistical Information System data. What we need to do now is to flesh out exactly what data elements and what formats and what periodicity, and so all the details of reporting data from the states that we need to put into the new data that we're going to be collecting from the states. And that's a work that it's taking some time. The states have different data systems. They have different ways of handling the data. And so we need to build that out extensively, but we do anticipate that we will learn from the transformed Medicaid Statistical Information System project, and we will then be able to do that. Yes, Mr. Platts, under the Affordable Care Act, we can hold the states accountable for doing that. We want to make sure that we're doing it in a way that is supportive for them and for us, and to get it done in a way that is not disruptive.
Certainly, the carrot versus the stick approach hopefully is effective. But the states are they being made aware that, yes, you will comply with this? We want to work hand in hand with you. But ultimately, if you don't, there is a stick at the available as well to ensure compliance in some form.
The Affordable Care Act spells that out quite nicely. Yes.
Final question to Ms. Yocum, Ms. King. GAO over the years has made a lot of recommendations, some of which have been embraced, others that haven't. If you had to highlight 1 or 2 of your recommendations that you would see as most important to ensuring program integrity, and what you would estimate the effectiveness of those recommendations would be in reducing that $65 billion improper payments number. What would that one or two recommendation be?
Well, on the Medicaid side, some of our recommendations are yet to come and will be forthcoming soon. I think the big areas where CMS needs to focus are on continuing to work with states on the data, continuing to collaborate with states on program integrity issues, and the collaborative audits are a very promising approach. We do think that their refocused view is a good one.
And certainly in the testimony, the collaborative approach has had much greater success than in the prior efforts kind of going.
That's correct.
Yeah.
Yep.
Ms. King?
And on the Medicare side, I think that we believe that CMS has taken some very important steps in the last couple of years. Certainly the new provider enrollment screening measures, the implementation of the fraud prevention system, and which we are currently evaluating. And we're also looking at prepayment edits. So we'll have more to say about that later. But certainly we see a positive direction.
Okay. Thank you. Mr. Towns?
Let me begin by thanking you, Mr. Chairman, for saying that I might be in the chair, but I need to let you know I'm retiring after 30 years. So,
actually, Mr. Towns, I apologize. You and I
definitely
are both going to
be
be gone, so somebody will be in both of these chairs.
I just want to make that clear. Thank you so much. But let me also ask, Mr. Chairman, that we hold the record open to get the information that we requested in reference to the indictment conviction numbers. I'd like to get that to see in terms of what the rate, of conviction is versus indictment. And of course, I want to say again, Mr. Chairman, that I really feel that we still have a lot of work to do. And I think that my question at this point in time would be, what can we do on this side that might be helpful to you? Sometimes, as legislators, we just point our finger and point our finger and point our finger. But if we want to really, really come up with a solution, so if there's something that we need to do, let us know. You could say it now, or you can put it to us in writing, because we would like to just correct it, because there is still some serious problems. And the fact that I think that information in is important. And if you're not getting the proper information in, then it's not going to help you in the end. So if you have suggestions to us as to what we might be able to do, I entertain that in my next few seconds.
Mr. Towns, if I just might clarify, we are working to identify the rates of investigations and convictions in both the criminal and civil fraud matters, and we've taken 2005 as a base year, and we're comparing it to 2010. That work is not quite done yet, but will be done later this year.
Okay, right. So we should not hold the record open, you're saying, to get the information? What are you saying? I want to make sure.
No, don't hold the record open, because it's not done yet, but we are close to finishing it.
But you will give us information before I retire.
Yes, sir.
Thank you. Thank you, Ms. Chairman.
Thank the gentleman. We will keep the record open for 2 weeks for that follow-on information that's been requested. Certainly appreciate that. Also, I would ask unanimous consent, have a statement for the record from the National Association of Medicaid Directors that focuses on their concern about the duplication of efforts at the Federal and State level and the importance of a seamless coordination, so we're not spending money on replicating what either we're already doing at the Federal level, at the State level, or vice versa. So without objection, so ordered. I want to thank all of our witnesses again. And I think as I read through the testimony in preparation for the hearing and the staff's legwork in preparing, and what we heard today is there are a lot of concerns about what's transpired in the past and the ineffectiveness of program integrity efforts. And as Mr. Lankford identified, where one example where $60 million spent to recoup less than that Obviously, that's not a good cost benefit to the American taxpayers. But I also think what comes true is that CMS, in conjunction with the Inspector General's office and GAO, is working forward in a way that is learning from the mistakes of the past and learning what worked in the past, such as collaborative efforts versus other approaches, and seeking to put in place a truly effective program integrity system that will bring down that improper payments number, hopefully dramatically, in the years ahead, because in doing so, we help us address both the debt that we have as a nation, but also those dollars are truly benefiting those in need of these health care services, whether it be Medicaid or Medicare, as opposed to lining the pockets of criminals and wrongdoers. So I'm encouraged that we're heading in the right direction as we need to. We do, the Ranking Member and I do have about 7 months left, so it gives us 7 more months to work with, not torment you in this partnership approach, and we look forward to that continued dialogue as we go forward. So this hearing stands adjourned.